start the session. They can directly join, sir.
Okay.
So 3, 2, 1. So we are live now. You can start our session. So over to you.
Shreejith?
Yeah. So shall I start?
Yes, sir. You can.
Okay. Can you see the screen now?
Yes, sir.
Good evening, everybody. At the outset, I would like to thank Lupin for this opportunity. Uh, Today evening, I'll be talking about diabetes and its reflection on mental health. So, not able to move it now.
Sir, any issue?
I was not able to move the slides.
Okay, sir.
I'll share it again.
Okay, sir. Okay. Sir, you should need to click on enable editing.
Sorry.
You should,
Hello. Yeah.
sir, first of all, please click on the slides. Click on the slides.
I'm clicking on the slide, but it is not moving.
Now change through the left and right arrow key.
Left and right arrow key.
Yeah, of your keyboard.
Yeah, that I know. Not that. The problems are not. I know how to do it, but the slides are not moving.
Okay, sir, no issue.
I don't know how to do it.
So just stop your sharing
Yeah, that's it.
and just check it whether you clicked on enable editing or not, sir.
Sorry.
Close the presentation and again open the presentation, sir.
It's stuck. Yeah. Sorry. So I should enable editing. What did you say?
Yes, sir. Yes, sir. You should click on enable editing, which you can see in the right top corner of your PPT slide, sir.
Click on enable editing.
Right, sir.
Where is it? Enable?
Sir, now click on the share screen. Click on the share screen button and share your entire screen instead of a particular PPT slides. Share your entire screen. Yeah. Now at there, please try to change it, sir. Try to move the slides.
Yeah.
Yeah, now it's moving.
So I'll be talking about diabetes and its reflection on mental health. Uh, there is a strong link between diabetes and psychiatry, and both diabetes and depression are relatively common. And diabetes is a risk factor for development of psychiatric disorders, and also the vice versa is also true. The psychiatric disorders are also risk factors for emergence of diabetes. And there are overlapping clinical presentations of diabetes and psychiatric disorders. There is interaction of medicines and impaired treatment adherence due to psychiatric problems can affect the treatment of diabetes. Talking of the implications of co-occurring diabetes and psychiatric conditions. There is an impaired quality of life. There is increased cost of care. Then can lead to poor treatment adherence. That can lead to poor glycemic control and increased hospital visits due to diabetic ketoacidosis, higher frequency of hospitalization, and higher rate of absenteeism and lack of visit to doctors. And depression negatively affects the glycemic control due to several problems. This study was published in Diabetic Research and Clinical Practice, and this shows that this orange curve is for depressed patients and the blue curve is non-depressed patients. And it shows that the HbA1c levels are significantly higher in patients who are having depression compared to those patients who do not have depression. Coming to the impact of glycemic control on cognition, this Accord Mind, this is a study of around 3,000 patients aged 55 to 80 years with type 2 diabetes treated with standard care or intensive glycemic control. And it was found that 20% of patients were found to have undetected cognitive impairment at baseline. And there is a greater mean total brain volume on MRI on intensive than standard treatment. And the baseline cognitive function, that is the DSST score, was significantly associated with risk of severe hypoglycemia. And coming to the screening, diabetes patients are screened for retinopathy, neuropathy, microalbuminuria, and screening for peripheral arterial cardiovascular disease. But cognitive impairment of dementia is often undiagnosed, and it is not screened actually due to perceived lack of benefit of early diagnosis. But there are benefits of timely detection. This timely detection can lead to early treatment and care, and it can lead to improve health-related quality of life, better clinical management. It can lead to reduce healthcare costs and burden of disease. Now, diagnostic psychiatric disorders, up to 45% of mental disorders go undetected among patients being treated for diabetes. And there is screening to be done under routine evaluation for pain and psychological distress, optimal treatment for better control quality of life. And diabetes is a depressogenic condition, probably due to the biochemical changes such as hypercortisolemia, increased leptin activity, altered glucose transportation, pro-inflammatory cytokines, and psychological factors such as stress, associated living with diabetes, poor treatment adherence, and behavioral factors such as sedentary lifestyle, smoking, overeating, etc. And among anxiety disorders, generalized anxiety disorders consistently increase the risk of diabetes. And psychosis itself is also a risk factor for diabetes, and it increase mortality risk and decrease medication compliance. And the mechanisms involved in the development of antipsychotic-related diabetes are unclear, but maybe due to serotonin receptor antagonism, weight gain, increased plasma lipids, leptin resistance, etc. And first generation antipsychotics increase the risk, especially phenothiazines. But the risk of second generation antipsychotics is even higher, such as clozapine, olanzapine, risperidone, etc. Increase the risk of diabetes, decay, and induced insulin resistance. And OGTT is most sensitive for detecting patients with impaired glucose homeostasis. Now, depression is a risk factor for onset of diabetes, onset of type 2 diabetes. It's a forest plot showing this. And the diagnosis of diabetes in patients with dementia indicates a need to reconsider aims of care and glucose habits, and indicated to review adherence to diabetes treatment, access nutrition status, a reminder to undertake a cardiovascular risk assessment, and the prompt to review hypoglycemia risk. There are several potential mediators of cognitive impairment in patients with type 2 diabetes. It includes genetic predisposition, microvascular disease, dyslipidemia, hypothalamus pituitary axis, adrenal axis dysregulation, hyperglycemia, advanced glycosylation products, depression, inflammatory mediators, recurrent hypoglycemia, drug therapy, etc. And the mechanisms that link diabetes and dementia include one is diabetic patients have coexisting hypertension, obesity, dyslipidemia, and this can lead to microvascular disease, brain infarcts, macrovascular disease, and also microvascular disease leading to ischemia. And hyperglycemia can lead to advanced glycation end products, mitochondrial dysfunction, oxidative stress, and insulin resistance, etc. So all these can contribute to diabetes and dementia. And cognitive impairment affects management of diabetes and treatment-related complications. Basically, due to the cognitive impairment, there is less involvement in diabetes self-care and monitoring. There is increased likelihood of severe hypoglycemia, increased risk of major cardiovascular events, increased risk of injuries and falls. And so efficient screening can improve long-term outcomes. And coming to the cognitive trajectories in patients with diabetes, there is a modest decline in cognition over time, even people without dementia. And this affects verbal memory, information processing speed, attention, and executive function. And the decrements affect all age groups and are slowly progressive over time. And these are not early manifestations of dementia. Dementia affects only a subset, and possible added effects of Alzheimer's or severe cerebral vascular disease also there. And coming to predictors of cognitive impairment and dementia in patients with diabetes, this was a pre-Mantle diabetes study, including diabetes patients who were aged more than 70 years. And in this study, almost 10% had dementia and 20% had cognitive impairment without dementia. And the major predictors of dementia were older age, diabetes duration, peripheral arterial disease, exercise was protective, etc. And treatment of depression improves insulin sensitivity. There is an increase in insulin sensitivity following treatment of depression. There is a decreased BMI, total fat mass, HbA1c, improved self-care bupropion. The reduced depression severity predicted HbA1c in both acute and maintenance phases. This is the quick screen for significant cognitive impairment in patients with diabetes. It is known as a mini cognitive screen. And in a study of older people with type 2 diabetes, the mini cognitive screen had a sensitivity of 86%, specificity of 91%, and a positive predictive value of 54%, and a negative predictive value of 98% for dementia. And this is a screen which can be done quickly in OPD basis also. So it includes 3 steps. Step one is ask the patient to repeat 3 unrelated words, such as apple, table, penny, and ask them to remember it. And second step is ask the patient to draw a clock face. So draw a clock and then set a time on that. And the third step is ask the patient to recall the 3 words from step one. So there are 3 steps. And if the three item recall is 0, the patient is definitely demented. 3 item recall is 3, then the patient is not demented. And if the 3 item recall is 1 to 2, and if the clock drawing test is abnormal, then the patient is demented, and the clock drawing test is normal, then the patient is not demented. And the degree of now coming to the drugs which increase the risk of diabetes. The risk of diabetes is high with clozapine and olanzapine. It is moderate with quetiapine, risperidone, and phenothiazines. And it is low with high potency first generation antipsychotics such as haloperidol. And the risk is minimal with aripiprazole, amisulpride, brexpiprazole, cardipressine, etc. So the thing to remember is that second generation antipsychotics have a higher risk compared to the first generation, and clozapine and olanzapine have the greatest risk. And these psychotropic drugs also induce metabolic syndrome. They induce weight gain, and metabolic syndrome usually induced by antipsychotics, TCAs, valproic acid, lithium, etc. And there is increased risk of decay with clozapine and olanzapine. And antipsychotic induced metabolic changes are proportional to weight gain. And several drugs cause weight gain. Clozapine can cause around 6 to 12 kg of weight gain. Quetiapine can cause around 2 to 4 kg of weight gain. Risperidone around 2 to 3 kg of weight gain. And aripiprazole and ciprasidan are weight neutral. Coming to drug interactions, there is not much of drug interactions between OHS and psychiatric drugs. Now, choosing an antidepressant, monoamino oxidase inhibitors, increase risk of hypoglycemia, orthostatic hypotension, dietary, etc. And TCAs can cause weight gain, increase glucose, cardiac conduction delay, but they are effective in treating diabetic neuropathy. But on the other hand, SSRIs improve glucose control, reduce insulin requirements among type 2 diabetes. And diagnosing depression, diabetes, inclusive approach causes a problem of overdiagnosing, whereas the exclusive approach causes a problem of underdiagnosing. Etiological approach may not be possible many times. And coming to achieve best clinical practice in a dementia care setting, there should be active screening for diabetes and also screening for complications of diabetes. And after screening, then complications should be treated appropriately, promote good nutrition, and reduce falls, hypoglycemia risk, etc. Review of medications, etc. And in a diabetic care setting, there should be awareness and screening for dementia, the screening for cognitive impairment using MMSE or a mini cog, as I said earlier, and management of cognitive deficit and minimize therapy risk. And avoid overly intensive management therapies and reduce the risk of hypoglycemia. And Sir Henry Maudsley commented that diabetes is the disease which often shows itself in families in which insanity prevails in the pathology of mind. Thank you. Thank you for the patient listening. Hello.
Yes, sir.
Yeah. And yeah.
My slides are visible, right?
Yeah.
Can I start?
Yes, sir, you can.
I'm audible, right?
Right, sir. Make it full screen mode, and after that you can start your session.
Okay. Yeah. So good evening, all. I'm Dr. Girish Menon, Assistant Professor, Department of Psychiatry, Jubilee Mission Medical College. First of all, I would like to thank Lupin, especially Shreejith, for giving me this opportunity today to talk on this topic, the clinical implications of diabetes in psychiatry. I think most of the things have been covered by Shreejith. I just want to add few of the stuffs that maybe he is not mentioned. I thought I'll just give a brief introduction about diabetes. I think most of all of you know about all these things, but just to give an idea that how uh, bad the situation
मारो तारा पति गयो तो
of diabetes in our country
एक
is
बहन
now. Worldwide, 465 million people have diabetes, even though less common in some of the Asian countries. But in India, it's very, very common, affecting almost 77 million people. 11.8% of adults above age 50 years have diabetes, and 2% of all deaths are due to diabetes. We have type 1, type 2, there is drug induced, and there is gestational diabetes mellitus. I'm not going to detail of all this diagnosis. I know you all must be knowing it very well. The initiations that we do apart from glucose levels is HbA1c, lipid profile. Risk factors for type 2
हम
diabetes
आए
is age, obesity,
चालू
hypertension,
के बाद session
hello.
मारो
I think somebody needs to mute the audio. Family history, gestational diabetes, and PCOD. These are the few risk factors for type 2 diabetes. Now, what is the impact of diabetes on quality of life? Definitely, it's a treatable illness, but not completely curable. Require intense lifestyle changes as well as complex treatment regimes in some of the cases. Strict glycemic control. Complications may be life-threatening and disabling, and complication of treatment also needs to be looked on. The medical complications, you have ISD, ischemic heart disease, cerebrovascular accidents, end-stage renal disease, neuropathic peripheral autonomic, ulcers, limb infections, gangrene, diabetic ketoacidosis, and non-ketotic hyperosmolar coma. Now, if you look from the psychological aspects, what are the factors that affect a person's response to illness or response to the treatment? In our psychiatry, if you look carefully, something called patient's personality and coping skills is one of the major factor which determines the patient's overall compliance in treatment. The psychosocial support, especially the family support, perception of sick role by the patient. As you have seen that many of the diabetic patients, especially in older patients, once they diagnose with diabetes and they feel that their diabetes is not controlled, they start playing the sick role, or they feel that they are sick, they are not able to do anything. That also plays a very important role in developing of psychiatric illnesses. Now, psychiatric comorbidity in diabetic mellitus. Now, Srijit already mentioned that how diabetes is connected to psychiatry. Now, as you know, diabetes can be a comorbidity of psychiatric illnesses. Psychiatric illness can lead to diabetes. They both can co-occur at the same time, and the treatment complications also. Now, psychological causes. Now, diabetes, initially it was considered as a psychosomatic disorder. Then there is something called diabetic personality. As you all know, we have type A personality, type B personality. Type A personality people are more prone to cardiovascular illnesses and also to some extent diabetic, which was given in Dunbar way back in 1943. Stress. Now, stress is one of a very major factor in causing diabetes and other psychiatric illnesses. Obviously, we all have different levels of stress in our life, but how we manage stress, how we recognize our stress, all those depends upon management of diabetes and in turn managing the psychiatric illness. how your coping skills are, how effective your coping skills and your cognitive styles, how much you are aware of the illness, and how much you're ready to take the treatment, and how much you're going to adhere to the treatment also has a very important role in management of diabetes and psychiatric illness. Now, depression. He has already mentioned. I'll just give a few because most of, to my best knowledge, are physician and endocrinologists. So, what are the main features of depression? Now, there are three core features of depression. One is loss of energy, loss of interest in previous pleasurable activities. Third, most important, is sadness of mood. Because as you all know, that depression is a mood disorder. So when we get a patient, we have to first evaluate how is his mood, whether there is any loss of energy, loss of interest in previous pleasurable activities, because many times patients do come with just the symptoms of loss of energy, and that can be a part of diabetes also. Along with that, we have other associated symptoms of depression, which includes feeling of hopelessness, helplessness, decreased concentration and attention, biological functions impaired, like impaired sleep pattern, decrease appetite or increase appetite in some atypical cases. We have suicidal ideations. So these things, along with the three main core features, if you can able to evaluate, then definitely you have to rule out depression. It is seen in 40% of patients of diabetes, 2 to 3 times higher rate in compared to general population, usually often missed, as I said, and affects all age groups. Now, how depression affects diabetes? Because a person is having depression, what it can cause is weight gain. That is because of, as I said, atypical depression, we have increased intake of food and reduced activity, because decreased psychomotor activity is one of the main features of depression. So that is leading to, again, weight gain, increased vascular risk because of comorbid substance abuse. As you all know, depression is one of the leading cause for substance abuse, like increased smoking, increased alcohol, and other obviously substances like cannabis. Hyperglycemia, there is hypothalamic pituitary adrenal axis dysfunction. I'm not going to detail of all that. And autonomic instability due to adrenogenic dysfunction. Now, it's a silent killer, depression, mind you. It reduces the quality of life, increases the morbidity due to diabetic complications, requires more hospitalization and mortality up to 5-fold. So as a clinician, if a patient comes, because many times we get patients who come to us just with the complaint of loss of energy, they have no other associated symptoms. But when you probe and when you ask leading questions like, do you feel like you don't have interest in activities that you enjoyed before? Your mood is usually sad in last few weeks. You don't able to concentrate. Your sleep is disturbed. This much questions is enough to give a hint that this patient is definitely having depression, and you need to either start something by yourself or immediately refer to a psychologist or a psychiatrist for further management. Now, what are the factors affecting illness behavior? In children, overprotection or rejection from the parent, over anxiety or over anxious parents, temperament of the children, like some children will be very impulsive, some children will be very anxious. In adolescents also the same thing is affecting. Adults, personality disorders like BPD, that is borderline personality disorder, or OCPD, that is obsessive compulsive disorder. This also affects the illness behavior. All this also can lead to emotional disorders in children, eating disorders, non-adherence to treatment, like people with having borderline personality, very difficult to make them understand the need for treatment, worsening of diabetic control, diabetic ketoacidosis, illness denial in some of the patients, and abnormal assumption of sick role, as I mentioned previously. Interventions, how we can manage them? It's a multi-system. Family therapy can be used. Group therapy, which includes improving the quality of life, coping skills can be trained, and community. Obviously, community also has to be psychoeducated, giving them the understanding that depression is a psychiatric illness. It can be endogenous. It's not always a person is doing it purposefully. You need to watch out for the symptoms, and the stigma that we have should be removed. All this can be done by community-based approach, which in turn can help in long-term management of diabetes also. Treatments, already mentioned, SSRIs are the most commonly used in treatment of depression. Sometimes nortriptyline and amitriptyline like TCS can be used. CBT, that is cognitive behavioral therapy, is effective in managing the emotions. Long-term treatment is usually beneficial in such patients because they may relapse, there may be multiple episodes. So at least 6 months to 1 year is minimum. Sometimes it can go up to 2 years also, the treatment, depending upon how severe the symptoms are, how delay we we got to treat the patients. All this also makes difference in the management. Now, next, after depression, what more commonly we can see is eating disorders. It's common than in general population in people with diabetes. A recent study showed that in a small scale study, out of 15 women, 14 had eating disorders who had diabetes. Again, access to, in our psychiatry, we have access 1, access 2, access 3, access 4. Access 2, it mainly deals with personality disorders, which includes borderline, that is BPD, and obsessive compulsive personality disorder. Anyway, borderline means the patient's having difficulty in managing their emotions. Emotional dysregulation is the core features of borderline personality disorder. And those people, it's very difficult to make them understand the need for treatment adherence. Atypical behaviors are usually seen, that is non-compliance rather than binging and purging, as in bulimia nervosa or anorexia nervosa. Antidepressants like fluoxetine and again CBT, that is cognitive behavior therapy, may be useful in such cases. Anxiety disorders are another commonly that we see, which includes fear of hypoglycemia, hypochondriasis, that is illness fear. Panic attacks sometimes can present as hypoglycemia, so we need to differentiate whether it is panic attack or hypoglycemic attack. Here also behavioral therapy, again along with group therapy and small amount of benzodiazepine will be very useful in such patients. Sexual disorders is another very commonly seen in patients with diabetes, even though it is underreported because many patients, again, stigma and the shame, they don't usually report to us unless you probe, or sometimes, patients feel that they have no other option left, so they come and report to you. Erectile dysfunction or ED usually seen in 32% of type 1 diabetes and around 46% in type 2, that is long-standing diabetic patients I'm talking about. We also see sometimes premature ejaculation also. In women, we see loss of libido, vaginal dryness. The causes may be organic, as you can make it out. Psychological also, sometimes once the person develops ED, the next time if he is not able to perform, it's called performance anxiety. That also leads to further erectile dysfunction. So what you can do is evaluate for the organic causes. Obviously, if the diabetes is not controlled, first manage controlling of diabetes, exercise, change in lifestyle, rule out any other drug causes. Sex therapies, couple therapies can be useful. And finally, we can consider drugs like sildenafil or alprostryl if the patient doesn't have any other comorbid hypertension or any cardiac illness. Now, cognitive disorders, he already mentioned Shreejith very well. Vascular dementia is what's commonly seen. Diabetes is obviously a risk factor in long-term patients. Vascular depression also is a factor. Cognitive deficiency usually seen after hypoglycemic episodes. Now, there is something called pseudo dementia. It's a very interesting term. Pseudo dementia is nothing but patient having depression presenting with complaints of loss of memory. We get so many patients, or you also would have come across patients who are complaining of loss of memory. But when you evaluate, you don't find any other comorbidity, or even the diabetic profile also will be within normal range. But the patient complains of loss of memory, and which, if you probe further, the patient may also have associated features of depression, like, as I mentioned before, sadness of mood, feeling of hopelessness, suicidal thoughts. And if you can treat that depression properly, even this loss of memory or pseudo dementia can be treated. Now, diabetes mellitus in psychiatric disorders. As you all know, schizophrenia is a very complex and very common psychiatric illness. Diabetes is one of the most common comorbidity we are seeing in long-term treatment. And one of the common reason is a drug-induced prevalence around 18 to 21%. Impaired glucose tolerance is also very commonly seen, that is pre-diabetic stage. And it contributes to morbidity and mortality and should be treated at the earliest. What are the factors or theories? Genetic linkage, nutritional and substance use factors. Low socioeconomic status is another factor. Neurobiological causes can be serotonin and neuropeptide Y factor, and neuroleptic, that is drug induced. Now, tardive dyskinesia is nothing but it's a movement disorder, that is drug induced movement disorder of psychiatry. Tardive is late onset of tardive, meaning is late onset. That means patient who's taking long-term antipsychotics may develop lip smacking, like this, or chewing movements. That may be also associated with diabetes, possibly related to dopaminergic mechanism. Ames score is very high, that is abnormal involuntary movement scale is very high in schizophrenic with diabetes. Risk may be not significant when atypical drugs are used in such patients. So guidelines says that we should have fasting blood sugar level monitored along with HbA1c at least 4 monthly in any patient with risk factors for diabetes. Psychoeducating patients and caregivers regarding the symptoms of diabetes is very important. Coming to next is bipolar mood disorder. We discuss about depression, that is one pole. The next pole is the extreme other end is mania or hypomania, affecting around 9 to 10% of hospitalized bipolars, and it is associated with severe course and more hospitalization. Theories include genetic, neuroendocrine, vascular lesions due to diabetes in the brain, and medications, which includes lithium, mood stabilizers like lithium, valproate, and atypicals. Management is no clear guidelines. Monitoring the neuroleptics, that is the drugs, weight neutral medications, mood stabilizers like carbamazepine and lamotrigine can be tried. Metformin also is considered to be beneficial, both type 2 and PCOD. Now, medications, Shreejith I already mentioned, but I'll just put few points. Our antipsychotics, there are two types of antipsychotics basically. There is typicals and atypicals. Typicals are older generation antipsychotics, which includes haloperidol, trifluoperazine, chlorpromazine, which are nowadays not much in use because of their more severe side effect profile, like developing EPS, too much of sedations, and so on. So nowadays, most preferred drugs are atypicals. In that, clozapine, olanzapine, risperidone, quetiapine are most commonly used. But clozapine and olanzapine have high propensity to develop diabetes or weight gain. Lesser for injectable typicals, that is older generation. And 36% patients on clozapine develop DM over the period of 5 years. And they also can cause sudden ketoacidosis. Mechanism here is mentioned already. So this is just a table. Clozapine is a drug of choice for treatment-resistant schizophrenia. It is a wonderful drug. We don't have any other option. So unfortunately, we have to weigh the risk-benefit ratio. If the patient's psychiatric illness is very severe and diabetes is more or less controlled, then we have to go for clozapine. We have no other option. Olanzapine, risperidone, quetiapine are all first-line treatment. But when all these drugs fail, we only have clozapine. Clozapine obviously have other side effects, like can cause granulocytosis, in some patients seizures, but if you see the benefit ratio, it's much higher than any of the drugs. Olanzapine comes next, risperidone, quetiapine is neutral, aripiprazole and ziprasidone also is very much having less effect on lipid profile and weight gain. Assessment, you have to take the proper family history, weight monitoring and BMI, blood pressure should be checked constantly, and lipid profile along with FPS. Same thing, we have to monitor this periodically. Now coming to mood stabilizers, which we commonly use for bipolar mood disorder. We commonly use, all the psychiatrists commonly use lithium and valproate. Valproate has a great potency to cause weight gain. Along with that, they can cause sedation, they can cause hair loss, they can cause risk for PCOD and period edema in some patients. Lithium also can cause weight gain and risk for hypothyroidism. Carbamazepine, lamotrigine, topiramate are usually having no effect on diabetes. Antidepressants, MAO inhibitors, usually nowadays we are not using it. Tricyclase, which includes amitriptyline, can cause hyperglycemia, weight gain, and increased appetite. SSRIs, which is most commonly used, and along with SNRIs, have improved glycemic control. Sertraline is most preferred than fluoxetine. Duloxetine is a very good drug, which has got less sexual dysfunction. Glycemic status has no effect and also is very effective in pain due to diabetic neuropathy. We also have gabapentin, which again is better tolerated than amitriptyline and have a role in bipolar disorder also, but not much studies are there. Metformin, effective in type 2 diabetes and PCOD. In some few studies have shown that it has antidepressant effects also. Dynamic and kinetic, I am not going details. So coming to the conclusion, evaluation, first thing, we have to always suspect the patient with diabetes, whether they have any underlying psychiatric illness like depression, anxiety. Search for the risk factors. Baseline investigations we have to be done. Whenever we as a psychiatrist see the cases of schizophrenia, all we have to do this. Along with that, lipid profile, weight monitoring, and psychoeducation and monitoring at the follow-up is also required for watching out any signs and symptoms of diabetes. Just briefly, drugs that we can, prefer is carbamazepine, lamotrigine. Typicals are aripiprazole and ziprasidone. SSRIs includes duloxetine, and newly there is a drug called vortioxetine, which has got very good profile on metabolic, less sexual side effects also. Better to avoid atypicals like olanzapine and clozapine, valproate, lithium, propranolol, and tricyclics. Now, the final slides. Management, overall, psychologically, we can manage, as I mentioned earlier, cognitive behavior therapy and behavioral therapy. group therapy, family therapy, and other individual therapies depending upon each case to case. Managing stress is very, very important. As you all know that we all have stress in our life, and stress is one of the very important factor causing diabetes and that leading to other psychiatric illnesses. So we have to recognize that we have a stress, and after that we need to bring about certain change in our behavior and in our lifestyle. And lifestyle includes our diet, exercise, sleep. These are the most three important factors. Social, patient support groups, education of the community, and community-based approach is also very important. Alternative, as I mentioned, exercise, yoga therapy is proven to be efficacious in depression and diabetes mellitus. So with all these things, we can definitely manage both diabetes and psychiatric illness together. But the most and foremost important thing is that we should not miss any of these things. If we can have that watch and carefulness in finding out these things, comorbidities, just like that, a patient with psychiatric illness come and get admitted, and if we feel that patient is getting tired, a patient is having excessive thirst, we definitely need to evaluate for diabetes and need to do for that. Similarly, if a patient comes to you who's having diabetes, comes and complains of loss of energy, loss of memory, or having depressive symptoms or any other anxiety or even sexual dysfunctions, we need to evaluate properly and manage them properly, and we can definitely do a good work. Thank you. Hello.
Sir, there are some questions in the Zoom chat.
um, I need to okay. First is from,
Yeah.
what are the steps to diagnose depression if I suspect depression in my diabetic patient, right?
Yes, sir.
Yeah. See, as I mentioned before, I again mention it. Depression, the core three features. One is sadness of mood or low mood, loss of interest in previous pleasurable activities, like the patient is used to enjoy reading paper, watching movie, going out with relatives, but he's not able to enjoy that. Loss of energy, he doesn't feel like getting up and doing anything. Along with that, they may also complain of feeling of hopelessness. They feel that future is very blank, bleak. They don't have any hope. They're not able to concentrate or focus on any of their activity. There will be sleep impairment or reduction of sleep or increased sleep also in some cases. Loss of appetite, guilt feeling. Some patients have guilt. In older patients who have, say for example, post stroke or post cardiac illnesses, they may have guilt feeling that because of me my family members are suffering. Along with that, they may also have suicidal thoughts. If you ask that, sometimes do you feel that you just sleep and don't wake up the next day, and the patient says, yes doctor, I feel like that. So this, in most of these symptoms, if you can identify in the patient, definitely the patient is having depression, and it should be lasting, or it should be there for at least 2 weeks. That is a diagnostic criteria. If it is just 1 or 2 days, it may be a grief reaction, say someone's death or some loss, that may result in depressive features. But depressive disorder, it has to be 2 weeks consistently for most period of the time of the day. Next question is, can you please repeat the drug's name that may induce metabolic disorder? Yeah, if you're talking about antipsychotics, as I mentioned, atypicals, that is newer general antipsychotics. In that, most notorious is clozapine, olanzapine, then comes risperidone. These are the three main drugs which, if your patient already has diabetes or metabolic disorder and it is not controlled at all, it's better to avoid. More safer is aripiprazole, quetiapine, or ziprasidone. But if you have tried all those drugs and the patient is absolutely not improving and you can somehow control diabetes, then you can go with risperidone. And if the patient is absolutely not improving in any treatment, then clozapine in small dose can be tried. Obviously you have to weigh the risk and benefit ratio. Any other question, Jay? I can see only 2 questions.
Yeah, so as of now, there are no any further questions. So we will wait for more few minutes if any delegates have their questions so that they can ask.
Yeah, meanwhile, I just can add also that stress factors are also very important in causing diabetes and obviously leading to psychiatric illness like depression, anxiety, and all that. So uh, we need to stress on factors that what are the causes of stressor, what we need to do when if we have stressor. So main, as I mentioned, I was just going through that change in behavior and change in lifestyle. This has to be done effectively and needs to be continued for a long period of time so that you can manage both diabetes and comorbid associated psychiatric illness also. Shreejith, എന്തെങ്കിലും add ചെയ്യാൻ add ചെയ്യാൻ diabetic side in.
Yeah. So I think that there is a strong link between stress and the development of diabetes. That is definitely there. Diabetes is a lifestyle disease, and unhealthy lifestyle, exercise, and stress are the most important factors. So it should be managed effectively, and plus also, if there are psychiatric disorders in a diabetic patient, diabetes, it is much more difficult to manage diabetes. That is, the patients are incompliant to treatment. They don't listen to your advice. So
Yeah,
coexisting psychiatric disorders makes it very, very difficult to manage a patient.
exactly, because we have seen our personal experience is that many of the patients who are having psychiatric illness like schizophrenia, they are ready to take any medication because they have that suspicion. Like schizophrenia, the most common symptom is delusion. That is, you have suspiciousness, you have fear that somebody will poison you or somebody will kill you. So they may not take any food or even medicine from the home. So which may include the diabetic medication also. And many of these people who have personality disorder also are very reluctant because they think that they know everything and they don't need anybody's help and they can manage by themselves. So people who are very adamant, stubborn people also, it's very difficult to make them understand the need for medication, even if it's psychiatric or even if it's diabetic also. So all those things we need to take into consideration. Cognitive behavior therapy in some patients are helpful in giving that insight. The main problem is insight, that is lack of awareness and awareness of the illness and need for treatment. So sometimes some patients are ready to go for psychologists to do psychotherapy or, as you say, counseling or whatever, cognitive behavior therapy. And if that is at least possible, then the psychologists do their best to see that the patient gets some amount of insight, and then they can at least take some of the basic life-saving medication like diabetes at least, and later on the psychiatric medications. And also I feel that many times patients come to our clinic, they may not you know uh, as somebody asks how to diagnose depression, some patients may come and just complain, as I mentioned, headache, somatic pains, headache, body pain, chest pain. That may be the only symptom, and they would have evaluated everywhere, neurologists, medicines, everywhere, I mean endocrinologists, but they don't find any cause. And when you start uh, probing, when you ask the bystanders that how the patient is feeling in the last few weeks, then you'll get the history that the patient is sad most of the time, his patient is crying, having a lot of stressor. And that if you can bring it out and then you can manage accordingly, then definitely the comorbid diabetes also can be controlled. Same with hypertension. Many patients who have a lot of stress may have increased BP, but the moment their stress gets controlled, their hypertension also becomes normal in most of the cases. So it's I think, as I say, biopsychosocial model, the environment, the social support, the patient's symptoms, the patient's awareness, all this is very important factor in managing such comorbidities, whether it's schizophrenia with diabetes or diabetes with depression. We have to look from all the angles and we need to help the patient.
They feel the psychological factors are not given much of an importance. We do not probe, and
Exactly. I mean, yeah, I mean, obviously in the busy
maybe
practice,
due
we
to
may,
lack of time, yeah,
yeah,
but
yeah, exactly. So
it's
busy
not
practice,
given adequate importance. That is what I feel.
yeah,
The
especially you have
role
to
of psychological factors.
Yeah, and especially you have to suspect in patients where the diabetes is not getting control after doing most of the things. There actually some reason. It can be psychological reason, it can be a personality factor, it can be underlying depression or anything. So once you suspect that the patient is not improving, then definitely you need to evaluate if possible or send to a psychologist to see that whether the patient is having any other concern, and if that can be managed, then I think even managing diabetes also will become more easy.
And many a time, some patients are reluctant to go to a psychiatrist.
Yeah,
That is also there. There is some sort of a stigma. So,
exactly.
when we advise the patient to go to a psychiatrist, they say
We don't want.
the patient feels bad. That is,
Yeah, maybe you can try sending to psychologist, and then they can convince and send. There is the next option, or you can just uh, psycho educate them why the need for it is and how it is going to help. At least maybe if they understand that a bit, maybe if out of 10 patients, if one patient listens to you and takes a help, then that's a great thing, I guess. Maybe not all.
hello. Any more questions?
No, sir, there are no more questions. So, should we wait or should we conclude the session?
Maybe we can wait for 2 more minutes at
Okay,
least.
okay.
Yeah, we can wait for 2 more minutes.
And is there any? I have one question to Dr. Girish.
Yeah.
Is there any problem with continuing SSRIs for a long duration?
See, SSRIs have a propensity to cause weight gain, but usually not unlike antipsychotics. It takes at least 3 to 4 years. So, as long as if the patient is not symptomatic, then obviously we usually do is taper the antidepressant, and then we stop it, say 1 to 2 years.
Okay.
But there are people who are genetically predisposed to gain weight. They may have a risk of gaining weight with SSRI also. So usually we try to taper within 6 months. But if the patient had multiple episodes of depression previously and there is a risk of suicide, definitely that's right. Again, weighing the risk and benefit, we may continue for at least 1 year to 2 years.
And apart from weight gain, there are lower long-term problems.
Sexual side effects is there.
That is there. Okay. That is
Yeah,
also
that's what I said. Yeah, loss of libido and all these things can be a long-term effect of diabetes also, and also the effect of SSRIs on this thing.
if the patient tolerates it, then there is no problem in it.
Yeah, if the patient, yeah, I mean, not all the patients will have all these side effects, but few patients, but majority of them usually tolerate. But usually 6 months to 1 year is what usually the patient's also comfortable taking, and we also evaluate if the patient is absolutely fine, have reached a pre-morbid level. That means before the starting of illness, if they reach to that stage and they are functioning very well, we taper on medication and then we stop it over the course of 2 to 3 weeks.
So it should be tapered and stopped. It should not be
Yes.
stopped abruptly, right?
Yeah. If the patient is on adequate dose or maximum dose, say acetylpram is on 20 milligram, then if we abruptly stop, there may be withdrawal symptoms, there may be relapse of symptoms immediately. So we usually taper and see when we are tapering how much the patient is symptom free. If there is any residual symptoms that can come out, if the patient is having slight loss of energy or loss of interest, or even sadness of mood, if we reduce from 20 to 10, it may again come up. But if nothing, then again we go from 10 to 5 and then we stop it. I think no more questions, then we can wind up.
I can make it. Yeah.
Yes, Rajesh.
Yes, sir. No more questions, sir.
So on behalf of organizers, sir, I would like to thank you for insightful and educative talk, sir. So thank you so much, sir, for your time.
Thank you. Thank you, Rajesh, for the invitation.
So with your question,
Thank you. Thank you.
Hello.
Now,
Rajesh പറഞ്ഞ കേട്ടില്ല.
No, sir.
കേൾക്കാം.
Sir, we can, sir.
അല്ല വേറെ ഒന്നുമില്ലല്ലോ.
yeah, I think we can wind up. Yeah.
Okay. Thank you. Thank you. Good night.
Thank you very much, sir. Yes, sir.
Okay.
Yeah. Thank you. Good night.